So good day to everybody. We're very happy to be here with you today. Myself, Robin Clay Williams and Ellen Deutsch are going to be talking about our experiences with in situ simulation and how that became what we believe is both a boundary spanner and an honest broker. All right. So when COVID began, we as the in situ simulation team were asked to conduct in situ simulations for a variety of microsystems within our organization. And this was different than how we usually conduct in situ simulation because typically with in situ simulations, we're responding to a unique need from a particular microsystem. And these unique needs are typically specific to that microsystem. What happened during the COVID pandemic is that individual microsystems were asking us for in situ simulation, and indeed they often had common challenges, and as well they identified various kinds of solutions. But in the absence of a centralized way to share or coordinate information, the in situ simulation team actually became both the content experts as well as a conduit of information to various microsystems within the organization. And just for your knowledge, these are two nurses placing a plastic barrier on a door at the beginning of an aerosol generating procedure to prevent the spread of COVID virus particles throughout the unit. Again, in situ simulations, as we typically conduct them, they're developed in various microsystems, and both the challenges as well as the solutions are usually siloed to that system and shared within that one microsystem, but not beyond that. But the simulations related to COVID were very different. We saw a variety of common challenges as well as a variety of solutions to address those challenges. And again, there was no central coordination or direction or mechanism to share the information that we were seeing. And again, in this particular photo, what you see is the buddy system in terms of two healthcare workers, each assisting the other with donning, with putting on personal protective equipment and making sure that it's adequately secured. So as the COVID pandemic evolved, in situ simulations became very different from the way we usually conduct them. Typically, in situ simulations are really isolated to the particular microsystem where we are conducting them. But in this case, in situ simulations became events attended by individuals from multiple units. They were spread by word of mouth. People shared with their healthcare workers on other units that they were going to be conducting an in situ simulation. And so various individuals from different microsystems would attend, and the entire group would share information relative to the common challenges, as well as information obtained from the original hotspots in New York City and in Europe. And again, this is a resuscitation, a simulation of a resuscitation with the plastic sheeting over the door, as well as the healthcare workers in full personal protective equipment. With these in situ simulations, we had an opportunity to test various inventions. So, for example, we started with the intubation box, which first started in Europe. And this was a heavy plexiglass box with an opening that allowed the healthcare worker to place a plastic tube in the patient's airway. This evolved to what is pictured in this photo, a Mayo stand with a plastic shower curtain that was much more flexible and adaptable to the height of the person who was intubating. As well, we tested various types of face visors that were produced by our biomedical engineers. In addition, we tested the resuscitation team configuration. So in this case, this is what we decided was the bare minimum of individuals that could be in a resuscitation and adequately cover all the roles, but not involving so many people that risk was increased to healthcare workers. We as a simulation team, as this evolved, we began intentionally collecting common challenges from the various microsystems and the people in the microsystems that, in which we were performing these simulations. And we also began to do something we hadn't done previously. When a representative of a microsystem came to us and asked us to conduct in situ simulations for COVID preparedness, what we began to do is prime those units. So we basically shared what we saw as commonly encountered challenges across the microsystems in which we had been working. As well, we also shared a menu of possible solutions, so that if that particular microsystem thought that a particular solution would work best for them, we could test that during their in situ simulations and make assessments as to whether that was going to work within their particular context. And again, this is the same resuscitation team intubating a simulated patient with COVID. So some of the common challenges we saw were donning and doffing, so both putting on and removing personal protective equipment in such a way as not to contaminate the healthcare worker, communication between inside and outside of the patient room, transferring supplies from outside of the room into the room itself, communicating the need for those supplies, as well as mitigating the risk for the healthcare professionals. So in this photo, you see healthcare workers wearing full personal protective equipment, including the sort of space helmet appearance, which is called a capper or a papper. It's basically a respirator that filters air. And what we used was something called glow germ, which is something that is used to test how well somebody washes their hands. And we actually aerosolized this from the mouth of the simulator to simulate an aerosol generating procedure such as intubation. And then following the simulation, we would use a UV light, which shows that the glow germ will actually light up if the healthcare worker has any glow germ on their personal protective equipment, which is where it should be, but not on their skin after they remove their personal protective equipment. One of the other changes that occurred for us was how we formatted our in situ simulation report. So we typically provide within about 24 or 48 hours of report back to each microsystem regarding the in situ simulation. And in this case, we changed our format. So we began by starting with what we call a bluff, a bottom line up front format. And that included typically 4 or 5 key learning points from the simulation that needed to be addressed, for example, for healthcare worker safety, for processes that were really necessary for the care of the COVID patient. The other piece that we added was lessons learned. And this was lessons learned from other microsystems. And so we included both the challenges as well as the solutions that we had identified in other microsystems. And what was really helpful about this is that we both provided key points up front as well as learnings from other microsystems. So one of the things that was really interesting and very different than how we had previously used in situ simulation is that as the in situ simulation team, we partnered with these various microsystems, and we became actually the content experts around things like donning and doffing and use of these various intubation adjuncts, because we were seeing these used across multiple units. We saw where the problems were, we saw how people became contaminated, and we became actually the content experts across these various microsystems, sharing information between these microsystems. And this was very different than how we typically use in situ simulation. It was really very novel, as well as it grew up organically. And we saw this happening and deliberately embraced that role. So it was really an interesting and fascinating experience how this grew up and became very deliberate and was a really innovative and novel way in how we use in situ simulation. So I'm going to turn this over to Ellen now to talk a little bit about this in terms of how these relationships evolved.
So Mary told me some about her experiences, and I was really intrigued by the way simulation had emerged as a very intentional boundary spanner who could communicate information between departments and was a trusted source of knowledge. And you can kind of think of these microsystems or units as a sort of horizontally equal if you think of a formal organizational hierarchy. So the simulation program could bring information between all of these and bring it bidirectionally. But in addition to that, the simulation program also emerged as a kind of honest broker that could bring information back or up to the administration. Again, if you're thinking of a traditional hierarchy, they could bring the information vertically to administration and also bring administration's edicts and information about resources back down to the all the units. So it spanned these boundaries both horizontally and vertically.
So if we wanted to put a theoretical framework around it, we could use social network analysis, which includes things like boundary spanners and honest brokers. So really the simulation team started off initially as a boundary spanner where they were really just a connection between two microsystems. But as they learned more and as they evolved, they became much more of a broker, so this impartial mediator. And as a broker, they weren't just connecting to systems, they were actually distributing information and they were distributing expertise. And as Ellen suggested, it was a great way of seeding information both horizontally between the microsystems, but also vertically within organisations where they could gain trust both from the senior management right down to the working level. And unlike formal information distribution systems, this one was incredibly fast. It was incredibly agile. And it was a two-way dissemination of information where the simulation group was disseminating information out, but also collecting and collating that information and disseminating it onwards to other groups. So a very nimble way of learning. And one of the other advantages they had was this unique eagle eye, big picture view where they could look across many microsystems and pick out the key points and the key critical things that they could then distribute that information onwards. So getting on to resilience, so looking at it from a resilience point of view, we could look at it in terms of this FRAM where we look at the resilient abilities of anticipate, respond, monitor and learn. Really this example is all about learning, a nimble continuous learning system and really a way of showing resilient learning. So this example here in the FRAM, we've got the simulation unit in blue and an emergency department that they might be disseminating their information to in orange. And if we start with learning in the bottom right, a number of outputs came out of the simulation group learning, and two of them were things like new processes and new protocols that would then be fed forward to the response of the emergency department. So that response, they could respond by incorporating those new processes, and those new protocols could control how they did their work. A further learning output from the simulation group was this increased understanding as they went from microsystem to microsystem. That could be fed forward to the emergency department that could facilitate them being able to anticipate better how they would respond and what they would need, whether they would need more information, which could be a precondition for them to respond, and also anticipate the areas of risk that they might encounter when they were responding, so thereby acting as a control for that response. And we talked about the two-way information from the response. They would then feed back to the simulation group these new ideas and the work is done version of those ideas that could be then was a monitoring type process that could then enable the simulation group to revise their protocols and processes and again further their learning. So a nice example of the sort of interconnected nature of learning with the other abilities in a very resilient, nimble learning system. And I think we probably might want to open it to the floor at this time for discussion.